Welcome everyone to this unique hybrid program today here as an ASH Satellite Symposium, adapting clinical practice to a rapidly changing therapeutic landscape in multiple myeloma. The speakers and the audience, we're used to a packed room at ASH and ready for rapid interactions with our audience. And so in this unique environment, we'll do our best to make this an engaging symposium. So I'm the program chair at Cedars-Sinai in Los Angeles. Very pleased to invite once again Jesus San Miguel, who's the Director of Clinical and Translational Medicine at the University of Navarra in Pamplona in Spain. So welcome, Jesus. Philippe Moreau, Professor of Clinical Hematology and the head of the Hematology Department, Université Hôtel Dieu in Nantes, France. Obviously, both Jesus and Philippe are participating virtually. And then in person in Atlanta, we have Vincent Rajkumar from the Mayo Clinic in Rochester, Minnesota. And Tom Martin, Clinical Professor of Medicine, University of California, San Francisco, UCSF. So welcome to them in person in the room in Atlanta. For those of you who are there, for your health and safety, it is important. All attendees must be fully vaccinated and masks are required. And I saw, from what I saw in the audience, people are wearing their masks. And it is important when you're not eating or drinking. And extra masks and sanitizers are available. The format for the symposium is the same as it has been in recent years. Each topic will be discussed, including a case presentation with interactive polling questions, where we will ask the audience to give their answer. We also ask the panel to give their answer. There will be a presentation by the faculty member, and then there will be a second audience vote, which will be followed by a panel discussion. Plus, we want to hear from the audience, both virtual and in person, and we will do our best to cover any questions coming in. As far as the polling, for the in-person polling, use the keypad, so hopefully you do have those, and they're the same as always. Select the response corresponding to your answer, and then to submit, you press the green square. Obviously, you can also in the room go to the microphone to ask a question. For online, the panel here will pop up on your screen. And so then you can go ahead and vote. If you want to ask a question, the query box will pop up and you can submit a question online. Okay, so just a few polling questions about our audience today. Which of the following best describes your role on the oncology care team? Physician, physician assistant, nurse practitioner, nurse, pharmacist, or an allied health professional? We'll wait for your answers on that. In the room, there is music. No music for us online, I'm afraid. Okay, so almost 80% are physicians this year. Actually, a little bit different than I recall from the past. Let's go to the next one. Which of the following best describes your specialty? Hematology, hem-onc, medical oncology, primary care, pharmacy, or translational science? Oh, we have music as well. Okay. Okay, so as you would expect, hematology or heme-onc. Okay, and the next question. Which setting best describes your practice? Academic, cancer center, hospital, physician-owned, federal government, or research? All right, so 40% academic, only 10% a hospital or healthcare system owned. Okay, all right. If you're practicing, how many patients with myeloma do you provide care for in a typical month? So this is the number per month. 5 to 10, 11 to 15, 15 to 20, or more than 20 in a typical month. So we tend to have rather a large clinical practice group. Okay, wow, more than 20, over half see over 20 a month. So really quite an experienced group participating today. So that's great. All right, I think that is the last polling question. So just to quickly review the agenda for everyone, divided up into sections as we have done in recent years, starting with early disease, evidence for treating high-risk smoldering myeloma, followed by the therapeutic strategies for newly diagnosed myeloma. Philippe Moreau will cover both eligible for transplant and ineligible for transplant, tailoring management for patients in first relapse, managing triple-class refractory, and evolving role for Bcma targeted therapies. And so we're really covering from the very early disease to the management of those with refractory relapse. Next slide. So with this, I'd like to turn it over to Jesus San Miguel, who will be presenting the evidence for treating high-risk smoldering myeloma. So Jesus, welcome in this virtual space, and we look forward to your presentation today.
Brian, thank you very much indeed. Unfortunately, I have a problem because I cannot have the slides on the full presentation. I can only see a small piece of the slides. Okay, I click on the three dots. Okay, now, got it.
You can see now?
Okay. Yeah.
Okay, good.
I'm ready now. Thank you very much indeed.
No worries.
Okay. I'm going to discuss with you a challenging case. This is a 51-year-old asymptomatic woman that presented with an IgA kappa paraprotein in a routine exam. The N component was small, 1.2 grams per deciliter, 12 grams per liter. Rest of the exams were normal, but not X-rays were done, no bone marrow. Okay. The diagnosis of NGAS was established with a follow-up every 6 months. And there was a slight continuous increase in the N component. I saw this patient 3 years later, and I decided to perform a more careful exam. At that time, the N component was 2.3. The free light chain ratio was 35. There was venous proteinuria, half a gram in 24 hours. In bone marrow, there were 32% plasma cell. Almost all the plasma cells were clonal, 97% of the plasma cells. And also there was translocation for 14 in the majority of the cells. The CT was negative, but the MRI showed one focal lesion. Therefore, a diagnosis of a smoldering was established. Next. Then here are the questions. In your current clinical practice, what would you recommend for this 51-year-old patient? Continue observation every 6 months until the diagnosis of active myeloma is made. Second, to begin treatment with lenalidomide-based regimen. Third, begin treatment, but with a triplet induction followed by autologous transplant, it's 51, or uncertain. Please respond. Okay. Almost 40% will continue follow-up every 6 months, while the rest of the people, the majority, will split into either start treatment with len or des or more intensive treatment. Okay, now let me move. What was the expert recommendations? And as you can see, split a position. I would say that the majority of them proposed treatment. Dr. Yuri, Vincent, myself, and Philippe was unsure because he is not sure if it's an active myeloma or a slim, while Thomas Martin preferred to continue observation, and 3-4 to 1. Okay, anyway, let's move now to the discussion of this case. Can you move the slides? Because I cannot move the slides. Okay, the topic of my presentation is rationale for evidence for treating high-risk smoldering patients and how to identify the risk of progression. Next, please. As you know, the risk of progression in smoldering patients is very different from one patient to the other. There are patients that behave like an MGAS, while another patient will have impending relapse in less than 1 year. In 2005, 2 papers reported on the possibility to identify a subgroup of patients with a time to progression, median time to progression of 2 years, and they were defined as high-risk smoldering patients. This was the Mayo classification that identified this patient based on the presence of both more than 10% plasma cells in the bone marrow, plus an N component of more than 3 grams per deciliter. The Spanish classification identified this category of high-risk smoldering, median time 2 years, based on the presence of most of the cells being clonal, more than 95% of the plasma cell being clonal, plus immunoparesis. Next. Last year, the International Myeloma Working Group proposed a classification that has become very popular, the 220-20, and is based on the presence of N component of more than 2 grams, 3 light chain ratio of more than 20, and more than 20% plasma cell. If the patient have 2 or 3 of these risk factors, the risk of progression in this patient is almost 46%, almost 50% at 2 years. Next, please. But as you know, in these patients, next, please. In these patients, the situation is totally different if you have 20% plasma cell, or if you have 40 or 50% plasma cell, or if the free light chain ratio is 20, or if it's 40 or 50. Therefore, a more precise and individualized score tool can be used to classify individuals by the actual risk of progression. And these risk factors can be done with a simple calculator. And if you can see here, if the risk score goes up to 12, the risk of progression is 72%. Next, please. But the question is, are other risk factors that allows you to identify risk of progression at 2 years, 50% risk of progression at 2 years? And the answer is clearly yes. The first one is the evolving pattern. And for evolving, we can include an M component or hemoglobin or the risk scoring. If you have an increase by more than 25% in 2 consecutive measurements within 6 months, this is an evolving smoldering patient and will progress in less than 2 years. If the hemoglobin decreased more than 0.5 grams in 1 year, high risk of progression. Or the risk scoring was recently reported by the Mayo Group. If you are intermediate risk with the 2020 and move to high risk, in this situation, they consider that this patient will need a therapeutic intervention. Benzo's proteinuria. Spanish group reported that the presence of more than 500 milligrams in 24 hours is associated with the time to progression of around 1 year. I will comment later on circulating plasma cell. Now, cytogenetics. Double hit patients with 414 plus 17p, whatever it is, high risk again of progression in 2 years. The genomic profiling in this ASCs meeting is going to be a very important presentation showing the value of mutation in DNA repair, MYC, and MAC kinase is Astra 2723, Irene Gabriel group, and I recommend you to attend also this presentation. What about the bone? MRI, the presence of a new focal lesion or increase on an existing focal lesion or progressive diffuse infiltration, high risk. Also a PET positive, but without lesions, again, is also high risk. But next, please, regarding circulating plasma cell, in this ASCs meeting, we are going to present Astra number 76, that circulating plasma cell can be detected in 78% of smoldering patients. And those patients with smoldering myeloma that have more than 0.02% circulating plasma cell have ultra high risk of progression, median 11 months. And this is an independent prognostic factor together with the M protein and the serum free light chain. And in fact, we are proposing that in the near future, we can replace the 2020 model by the 0.2 2020 model. In other words, we replace the 20% plasma cell by the circulating plasma cell, because also it's easy to measure and you can do sequentially every 3, every 6 months. And in fact, I think this the measure of circulating tumor cell should be included in the workup of smoldering patients. Next, please. Therefore, we have a lot of evidence about how to identify the high-risk patient. Now, to treat or not to treat. We know that early detection and intervention is a prerequisite for cure in most malignancy, in prostate, breast cancer, lung cancer. Why not in multiple myeloma? Probably because some people consider that we can induce clonal selection or toxicities, but clonal selection occurs more frequently if you delay the treatment instead of eradicating the clone. Don't forget that. And this was part of the rationale why now there are so many trials devoted to try to identify the value of an early intervention in high-risk smoldering patients. And you can have two attitudes, to delay the disease progression or to try to cure by an early intervention. Regarding delaying disease progression, there are 2 randomized phase 3 randomized trials. I want to emphasize that I have phase 3 randomized trials. The first one is the Spanish trial. Now with a median follow-up of more than 12 years. And this is very important to consider. Very long follow-up. In this trial was Lendex versus observation. In the observation arm, what is the median time to progression? 2 years. The expected one for a good identified risk of progression. What is in the experimental arm, the Lendex? 9.5 years. This means 7 years delay in the progression. And this was associated with a 43 reduction in the risk of death, with a hazard ratio for the time to progression of 0.25. And the same hazard ratio has been observed in another phase 3 randomized study conducted in the United States that shows that by Sagarlonial also a significant benefit. They included high risk and intermediate risk. And the major benefit is clearly for the high risk smoldering. I will not treat intermediate, but for the high risk, the hazard ratio was 0.15. In other words, more than 85 reduction in risk of progression in this patient. Next, please. There are also one question that people say, okay, but probably by early treatment, you can induce more resistant relapses. In the Spanish study, we have analyzed carefully this. And here you have the overall survival from the time of progression to active disease in both the Lendex and the observation arm. And as you can see clearly, early treatment does not induce more resistant relapses. Moreover, in the observation arm, patients receive the optimal treatment at the time of progression. Next, please. There are now several phase 2 clinical trials for intermediate and high-risk patients. And these clinical trials based on Lendex as the backbone, ELO Lendex, ISA Lendex are showing a very high time progression-free survival, 100%, 90% progression-free survival, with a CR rate ranging between 6 and 31%. I should mention that the ISA-RD phase 2 has promoted a phase 3 randomized trial that is ongoing. Particularly exciting data were reported by Ola Landgren with KRD, 8 cycles followed by Len maintenance. It's impressive, the result, although I should emphasize the number of patients is small, around 50, and the follow-up is around 30 months, but they have presented 72% patients in CR with 53% patients with sustained MRD negativity at 5 years. Also, monoclonal antibodies are being explored in this setting. Isatuximab and daratumumab, the CR rate is around 10%. I mean, they don't induce high CR rate, but if you look to the PFS at 1 or 2 years, 90%, 95% of the patients have not progressed yet, what I think is the endpoint of this type of analysis. Next, please. The other alternative is to try to cure. And this was the approach of the Spanish group in the CESAR trial. We include the same approach for active myeloma in young patients. In this case, KRD, 6-cycle autologous transplant, consolidation, and maintenance for 2 years. The endpoint was MRD negativity. It was to achieve around 50% MRD negativity after autologous transplant. In this case, was 63% after autologous transplant. After consolidation, 68%, and patients after 2 years maintain 52% of the patients in MRD negative status. At 5 years, 94% of the patients remain alive and progression-free, and 95% of the patients remain alive. Next, please. A very similar study with a curative approach is being developed in the United States. Here in this case is KRD plus daratumumab. We have no data yet about the efficacy, but we have data that a regime is well tolerated and is promising. Next, please. Therefore, and this is the end of my presentation, I have still the question, to treat or not to treat? And an additional question, should the doctor decide for the patient or should the patient decide by themselves after an appropriate information? Please, can we go now to the initial question, just to repeat again? Okay, you remember this was a 51-year-old lady that I presented with a 34, a phenyl chain ratio of 34, 35% plasma cells, or whatever, plus the cytogenetic abnormality, plus a focal issue. Okay, continue observation, begin treatment with Lendex, begin treatment followed by autologous or uncertain. Please respond.
Mm-hmm. Oh, there we go. Oh, that's
okay.
very helpful.
Okay, I think we have convinced at least half of the audience that was in pro no treatment. We have convinced them to move to the treatment. But let me show you another case. Next, please. And I want you, look, case 1 you don't need to read. It's the first case. It's the case that we have been discussing. The second one, the same, 51-year-old lady, a paraprotein of 2 grams, free light chain of 25, normal renal function, everything normal. There is no 414, there is no focal lesion, there is no clonal plasma cell, only a 50% plasma cell, but has a lytic lesion in the skull and one in the clavicle. The question is, which of the following patient is higher risk? The first one or the second one? In the second one is you have Krd. You have a lytic lesion, or a couple of lytic lesions, and you will treat. But my question is, who is higher risk? In which one is going to be the life probably shorter? Case 1, B, both similar and sure? Please respond. Okay, I like this because at least some people, many people, I would say that the majority of the people, only 31% consider that case B is more risk. The other people are either unsure or consider that both are quite similar. Okay, thank you very much. I think I stop here and we can move for the discussion.
Yes, we have the
we had the expert recommendation that is in the same line, either unsure or have a similar risk. In other words, we consider that these patients are quite similar.
Right. Quite a range of opinions, actually. So there's a question came in from the audience already, but perhaps we can focus, first of all, Jesus, on the recommendation for treatment. Yourself and myself, we recommended a triplet plus transplant, and Tom was unsure, and Vincent recommended a lenalidomide combination. Maybe we could ask Vincent first to comment, so we can hear from someone who is live in the audience. Vincent, do you want to comment? What treatment would you actually recommend at this time in clinical practice?
So thanks, Jesus. Thanks, Brian. I hope you can hear me in the audience.
Very well.
This is a tough case because what Dr. San Miguel did was the patient's not just high-risk smoldering myeloma with more than 2 grams M spike, more than 20 for the light chain ratio, and more than 20% for the bone marrow plasma cells, the 20-20 criteria. Any 2 of the 3 is enough to call somebody as high-risk smoldering, and that's the group that I recommend Len or Lendex rather than observation. This patient has all 3, and in addition has a 414, which is a high risk factor, and in addition has 1 focal lesion on MRI. So in these kind of circumstances, we actually have better data than what I would have had if somebody just told me the first 3 variables. That's why the IMWG paper that Dr. San Miguel showed, where you have the scoring system, comes into view. And when you score the patient here, this patient's risk of progression in 2 years is 80%, almost the same as what we have done for reclassifying asymptomatic patients to multiple myeloma. So this is a tough one, and I think for this particular patient, it would be very reasonable, and that half of you chose the standard myeloma therapy that with transplant and everything else. But in general, for high-risk smoldering myeloma, if you ask me, it's better to do Len or Lendex rather than observation, and that's coming from 2 randomized trials. You will not be able to catch the progression even if you follow the people monthly. Whether it's better to treat Lendex or a myeloma-like therapy is not known. I don't know the answer, and that's why we are doing a randomized controlled trial. It's almost halfway accrued. It's available in the United States, DARA RD versus RD. So if you're really torn, just put the patient on that trial. That would be my choice.
Thanks, Vincent. So, yeah. So Tom, maybe you can comment. You were unsure. Do you want to explain your uncertainty?
So I agree honestly with everybody in that this was a very difficult case. And I would say I have 2 issues that this case brings up, and we talk about it actually in our rounds at UCSF all the time, whether to start somebody with high-risk smoldering myeloma or not. One of the issues is we like to see the movie to continue to see the movie rather than individual snapshots. So this is a person I would follow. I wouldn't really follow 6 months. I would follow closer, maybe every 2 months, every 3 months. But the other issue is that if we start therapy now, the patient never met criteria for IMWG diagnosis of active myeloma. In almost every trial that we have in relapse refractory disease requires that they have the diagnosis of active myeloma at some point during their stay. So I actually would probably would watch them a little bit longer. If I am going to start therapy on these people, I would start therapy with an aggressive regimen, just like everybody said, with triplet or quadruplet induction therapy, transplant, and treat them like they had active multiple myeloma, aggressive multiple myeloma.
So Tom, you do bring up a point. We have a question from the audience, which I think has been coming up more and more now, is that if a patient with smoldering myeloma is treated and then they relapse, what do we call that?
Right.
What do we call that?
I mean, it depends. If there is a biochemical relapse, he can continue as an smoldering. But if they develop Krd, it's myeloma.
Right. So if it's a biochemical relapse, I think one of the points Tom is making is that it might be difficult to fit that patient into a treatment protocol.
Yeah, but if it's a biochemical relapse, in any case, you will not be able to include as active myeloma.
Exactly.
But I think most of the people you'd pick up on biochemical, because you're following them closely now. You're following them closely while you're giving them treatment. You're going to pick them up biochemically before they're going to hopefully have symptoms, et cetera. So that's my conundrum. Right. And I think both ways are actually appropriate.
Right.
It's true. In my presentation, I mentioned that when I saw this patient, for me was a surprise because apparently it was an MGAS, but when I evaluated and looking back to the N component, in the last 6 months, the N component has increased more than 0.5 grams in the last 6 months. And this patient, is was going very soon to progress into active disease with one focal lesion. In fact, the patient was a bit reluctant to start treatment, and 3 months later, he started with pain, and there was a second focal lesion. I didn't mention that because I want to keep the case as a smoldering case. But my personal recommendation is for a doctor that don't want to treat by any reason, is at least in this type of patients to do a very close follow-up every 2 months. And if you have an evolving pattern, please don't wait, because you are only favoring a more resistant clone. Right. And I think myeloma is a very aggressive disease, just to wait for that. And another comment that I want to make is I'm totally agree with Vincent. In the majority of smoldering patients, when I high risk or ultra high risk, we decide to treat, I prefer to go for Blendex or something like that. But if he's young, that's his case, I propose her to go to the transplant.
One other question we have from Philippe, yes, go ahead.
Yes, to echo your point, Jesus, I fully agree. When you propose your questions, you mentioned option 1, continue observation and a 6-month follow-up until diagnosis of active myeloma. And for this specific patient, I will do the same. I will do a follow-up every 2 months and not 6 months. And so that's why I was unsure about the treatment as well, because you are proposing a treatment or not until the diagnosis of an active myeloma. But now we have also the slim Krd. And if the patient is fulfilling the slim Krd diagnosis, maybe we can treat before an active symptomatic myeloma. That's also something. And when you are looking at your patient case, in fact, I did calculate the score of your patient according to the paper that was published by Marivi. And this specific patient, in fact, had a score of 2 for the free light chain, a score of 3 for the M spike, a score of 3 for the percentage of plasma cells, and a score of 2 as well for FISH, because he had a 414 translocation, that's a score of 2. So overall, the score was 10. And according to your paper and to your classification, when you have a total risk score of 10, your 2-year progression your risk of progression at 2 years is 48%. So that's not 80%. So that's why I'm still unsure. You know, that's not that simple. So your case was a very difficult one for sure, Jesus.
Maybe we need that 0.2 plasma cells in the blood to tip the balance.
Yeah, I think that your presentation that you will do tomorrow, if I remember correctly, on circulating tumor cells is very, very important.
Yes, exactly. We have one more question.
I think
from the
Vincent
audience.
wants to make a comment.
Brian?
Vincent?
Brian, can I make one comment?
Of course.
Okay. So in response to Tom's comment, I just want to clarify again. We did this experiment, and let's not forget that. The ECOG study, the Spanish study, in ECOG, United States, we randomized people to observation versus treatment with LEN. Patients were followed monthly. The physicians knew the M spike changing everything. Yet, in the high-risk smoldering myeloma, there was a 90% reduction in end organ damage with lenalidomide therapy. And in my experience, you never catch the progression in time. The progression happens in between visits. So if you're going to say, I'll watch the patient carefully and I'll catch it before it happens, that experiment was done and it failed. Our physicians in the United States are not able to catch it in time. Same thing in Spain. And so keep saying that we can catch it in time misses the point that we've done the experiment.
No, Philippe, let me add one point, Philippe. The score in this patient was 10 and was true, but in addition it has a focal lesion and Benjamin's proteinuria of more than 500. Therefore, this patient, as Vincent has guessed, has over 80% probably risk of progression. Let me, for the audience, to make a comment, because I think it's very important. In the CESAR trial, out of 126 patients, the CESAR trial is going to be presented by Mary in a poster session, and that date, the update information. But out of 126 patients, in 36 were screening failures, and 77% of these screening failures were due to bone disease, lytic lesions, that in the conventional X-ray were not visualized. In the smoldering case with the 220, not to treat, please do the best possible evaluation of the patient.
Yeah, fully agree. I think unfortunately we need to move on. There was one last question, maybe you can answer quickly, which was the length of the treatment. 2
years in the Spanish trial.
2 years, yeah. So not open-ended.
No.
All right, so we do need to move on. We're a few minutes late.
And don't forget, 7 years different in PFS. 9 years median PFS. People forget about that. Imagine this difference in whatever randomized trial for active myeloma.
I cannot hear the audio.
All right, we need to move ahead. Thank you for that active discussion.
Okay.
Actually, a very important topic with a lot of new information being presented at ASH this year, as you mentioned, Philippe. So I will actually turn it over to you now, Philippe, for the case discussion for topic 2, current therapies for newly diagnosed myeloma, starting with transplant eligible and then moving on to transplant ineligible. And so I'll turn it over to you, Philippe, for those joint discussions.
Thank you, Brian. And this is the patient case, in fact. The patient is 60-year-old with bone pain, anemia, an M spike of 4.2 gram per deciliter, 30% plasma cells, cytogenetics by FISH is showing a translocation 1114 with a low-dose whole body CT showing diffuse bone lesions. LDH is normal, the beta-2-MYC level is 2.5. So the patient is ISS1, revised ISS1 with a symptomatic multiple myeloma. He's 60. So the question for you, and you can vote now, in fact, in your are you proposing VRD, 4 cycles, stem cell transplantation and LEN maintenance, VTD DARA, stem cell transplantation and LEN maintenance, VRD DARA times 4, stem cell transplantation and LEN maintenance, VRD, 8 cycles and LEN maintenance, KRD DARA, 8 cycles, LEN maintenance, VCD times 4, stem cell and LEN maintenance, or not sure. So please vote. Okay, so for the majority, the great majority of you, that stem cell transplantation upfront, and in fact, no stem cell transplantation for only 2% of the audience, quite interesting. And regarding induction, we are splitted here between triplet induction and quadruplet induction. So interesting. So let's go back to the slide deck, please. So important issues that we are going to discuss, triplet or quadruplet. Oh, sorry.
Do you want to, just show the...
The experts, the experts' recommendation, that's quite interesting. So you see that for Brian, Tom, and Vincent, a triplet induction with VRD. And for Jesus and myself, we are proposing a quadruplet incorporating daratumumab. So quite interesting, let's say, and we will see, we will discuss these important issues, in fact. Triplet or quadruplet induction, frontline or delayed stem cell transplantation. Do we need more aggressive strategies for high-risk disease? And maintenance, are we going to use LEN single agent or 2 drugs? In fact, when you are looking at the European EHA and ESMO guidelines recently published, before stem cell transplantation that is systematically proposed, you see that the first options for induction are either VRD or VTD plus daratumumab, a quadruplet. And we are proposing a single stem cell transplantation and LEN maintenance. When looking at the MSMART algorithm of study, for patients with standard risk disease, VRD is the best option, and autologous stem cell transplantation is preferred, but not systematically proposed, and LEN maintenance. But for high-risk disease, our colleagues are proposing a quadruplet induction with VRD plus daratumumab, and they may consider tandem stem cell transplantation as well, with a maintenance that is based on bortezomib maintenance. So first question, triplet or quadruplet? VRD is very well established, very popular, many trials looking at VRD and stem cell transplantation. This one coming from the French group, comparing VRD alone or VRD plus stem cell transplantation. And the study was updated at last ASH, showing that VRD plus stem cell transplantation upfront is associated in red with a better progression-free survival, and at 8 years, 30% of the patients did not relapse. We also have VRD tested by the Spanish group, 6 VRD upfront, stem cell transplantation, and maintenance. And interestingly, they did assess systematically MRD negativity. And you see that MRD negativity was much higher for patients with standard risk disease as compared with high risk disease. And when looking at PFS on the left-hand side and OS on the right-hand side of the slide, you see that those patients reaching MRD negativity, they have an outstanding outcome, both for PFS and OS. And this is true also for patients with high-risk disease. So the goal of our strategy is really now to reach MRD negativity if possible. What about quadruplet induction? You are knowing the results of the VTD versus DARA VTD study from the Cassiope that was associated with a high rate of MRD negativity before maintenance, 64%, 10 to the minus 5, with DARA versus 44% without daratumumab. The study was updated and reported in the Lancet recently, showing that with daratumumab upfront, there is a benefit in terms of PFS, but also a trend for an overall survival benefit. And during this meeting, we are going to hear about the results of MRD negativity and sustained MRD negativity into Cassiope. And you see that those patients with a sustained MRD negativity at the top with daratumumab are enjoying an outstanding PFS as well. So should we use VRD or VTD DARA? In fact, we will never have any head-to-head comparison of this triplet versus this quadruplet regimen. But we did a matched adjusted indirect comparison of VRD versus VTD DARA. And VTD DARA seems to be associated with a better PFS, but also a better overall survival. That's an indirect comparison, but that may open some questions for sure. But why not using VRD DARA? Since VRD is very popular, we have some data with VRD DARA coming from the Griffin study, a prospective phase 2 trial on 200 patients, in fact. The study will be updated during this meeting, and tomorrow we are going to hear about those updated results of the Griffin study. And you see that with now a quite long follow-up, after 24 months of maintenance, the MRD negativity rate is much higher in the DARA arm of the study, and this now translating into a better progression-free survival. You see the hazard ratio of 0.46 in favor of the VRD DARA arm of the study, indicating potentially that the quadruplet with VRD plus DARA is a better regimen. So what about consolidation now? You are knowing very well the STAMINA study run in the US. After stem cell transplantation, patients were randomized to no consolidation and LEN maintenance, VRD consolidation and LEN maintenance, or a tandem stem cell transplantation and LEN maintenance. And you know that the progression-free survival was identical in the three arms of the study, but overall survival as well was not different, suggesting that we don't need consolidation. But in Europe, the EMN02 study also tested VRD ×2 consolidation or no consolidation. And the study was recently, a few weeks ago, published in the GCO, showing that VRD consolidation was able to increase the progression-free survival rates. What about tandem stem cell transplantation? That is quite often proposed for high-risk disease in the mSMART algorithm, but also in the EHA and ESMO guidelines. In fact, the EMN02 study looked as well at single versus tandem stem cell transplantation. And the PFS was improved with tandem, but also overall survival. And the benefit was more important in patients with high-risk disease. So it is true that some centers are proposing a tandem, if possible, in patients only with high-risk disease. And what about maintenance? We know that LEN is approved, is the standard of care. LEN maintenance based on this meta-analysis of LEN maintenance versus no maintenance or placebo with an overall survival benefit, and all of us are using LEN maintenance following stem cell transplantation. But can we use another drug such as ixazomib? And you are aware of this Tourmaline MM3 study that looked in a placebo-controlled phase 3 trial at ixazomib orally or placebo. And the benefit was significant in terms of PFS, but to my opinion, marginal, with only a 5-month benefit in terms of PFS and no OS benefit. But during this meeting again, the Spanish group is going to show a very important trial, to my opinion, with disappointing results. Our colleagues and Jesus and many centers in Spain looked at LEN-DEX maintenance versus LEN-DEX plus ixazomib, so a combination of an IMiD and a PI. And disappointingly, there is no difference in terms of PFS. maybe because ixazomib is not the more potent proteasome inhibitor. On the opposite, we also have this paper published a few days ago in the Lancet Oncology looking at carfilzomib maintenance in the Forte study. Patients were randomized after induction to receive len maintenance or len plus carfilzomib, so a combination of two agents with carfilzomib that is a more potent proteasome inhibitor. And Dr. Francesca Guy did show perfectly that carfil plus len maintenance was able to improve the progression-free survival with a hazard ratio of 0.6 in favor of 2 drugs instead of 1. And ongoing trials are also looking at len versus len plus daratumumab. And that's also interesting to combine potentially a NIMID plus a CD38 antibody. And to close my talk, I will discuss the paper from the group of New York looking at Krd Daratumumab, a quadruplet very active combination without stem cell transplantation. And based on these results, our colleagues are claiming that we may be able to avoid and postpone stem cell transplantation systematically because Krd Dara is associated with a high rate of MRD negativity. That is very important and potentially the goal to achieve, and a very good overall survival as well, and progression-free survival. But before claiming that we can use a quadruplet without stem cell transplantation, we need a phase 3 study. And this study is currently proposed in France by the French IFM group. We are going to use a quadruplet induction, very active with isatuximab KRD, 6 cycles. And then after induction, we are going to assess systematically MRD. And when patients will be MRD negative, so good risk patient, on the top of the slides, patients will be randomized to KRD isatuximab consolidation or stem cell transplantation with ISA KRD consolidation 2 cycles. So we will be able to demonstrate if we need yes or no in patients MRD negative, the use of a systematic stem cell transplantation upfront. And this is, to my knowledge, one of the first randomized study looking at MRD as a driver to the strategy. And we call this study MIDAS, Minimal Residual Disease Adapted Strategy. So now let's return to our case, in fact. You remember revised ISS1, symptomatic myeloma, 60 years. So now what are you proposing in terms of treatment? Please vote. Oh, yes. Okay, so now maybe quadruplet will be proposed for more physicians and more patients. That's interesting to see that we are moving potentially from a triplet to a quadruplet, and VRd Dara may become in the future the standard of care. An interesting conclusion. Thank you.
Right. So we will save the discussion until your second presentation, okay?
Okay, Brian, thank you. So let's speak about now patients that are not eligible for autologous stem cell transplantation. So this is the patient case, a 74-year-old female with diffuse bone pain, anemia, an M spike of 5.2 grams per deciliter, 32% of plasma cells, FISH analysis, no adverse prognostic factors, diffuse bone lesions on the low-dose whole body CT, but the serum LDH is upper limit of normal. The beta-2 MIC is 5.7, symptomatic myeloma, ISS3, revised ISS3. So for this specific patient, what are you proposing? Symptomatic myeloma, 74-year-old lady. The first option, VRD times 8, followed by Lendex until progression, VMP DARA, followed by DARA maintenance until progression, Lendex until progression, Lendex DARA, DRD until progression, VMP times 9, VCD times 6, followed by Len until progression. So please vote. Okay, so the first choice for half of the audience, DRD until progression. For 30% of you, VRD times 8, followed by Lendex until disease progression. Brian will be happy about the SWOG 777 study. And VMP DARA, followed by DARA maintenance until progression. That's the Alcione study. So interesting to discuss about these treatment options. So can we go back? Yeah. So what about our experts? What are they proposing? Brian, DRD. Thomas isn't sure. Vincent, VRD times 8, followed by Lendex until disease progression, the SWOG study. And Jesus, VRD times 8, followed by Lendex as well, because that's not available in all centers in Spain. But VMP DARA maintenance, that's the Alcione study, and VMP is very popular, as you know, in Spain. So quite interesting to see those differences, in fact. The first three choices of the audience. So important issues for elderly patients. Do we need to use combinations with CD38 upfront? Are we using the frailty score systematically? How to manage adverse events in this elderly patient population with comorbidities? And are we selecting a fixed duration of treatment or until progression? So that's also a challenge. So when looking again at the European guidelines, the first options are the following: DRD, DARA VMP, and VRD, followed by Lendex, exactly the first three choices of our audience today. What about the MSMART algorithm? Standard risk patients, DRD or VRD for 9 cycles, followed by Len maintenance. And for high-risk disease, DRD or VRD followed by bortezomib maintenance instead. So high-risk bortezomib for maintenance instead of Len. So when discussing VRD followed by Lendex, that's the SWOG 777 study published by Brian Dury in the Lancet and updated, in fact, last year in Blood Cancer Journal. You see that there is a true PFS benefit for VRD over Lendex. That's true for patients above the age of 65. That's also true for patients above the age of 75. But when looking at overall survival, we only have, for patients above the age of 65 years, a trend for a better overall survival. The OS difference is not statistically significant. Nevertheless, the overall survival is quite good, let's say, with VRD followed by Lendex until progression. That's a very popular regimen. In terms of toxicity, you see that there is a higher rate of infection with VRD as compared with Lendex, and also a higher rate, as expected, of peripheral neuropathy. The second choice is VMP plus Daratumumab, and that's based on the Alcione study published in the New England and updated as well with a longer follow-up. This study proposed a fixed duration of VMP, 9 cycles, or a treatment until progression with Daratumumab during 9 cycles, followed by DARA maintenance. And obviously, the progression-free survival was in favor of the DARA arm, followed by DARA maintenance. And you see that the median PFS is not very different from the one that is proposed into the SWOG study. That's 36 months, it was 4 months in the SWOG for elderly patients. But importantly, there is an overall survival benefit that is significant with a hazard ratio of 0.6. In terms of toxicity, in the DARA group, we have a higher rate of infection as well, and especially pneumonia. And the third option is the DRD regimen based on the MAIA study published 2 years ago in the New England and recently updated as well for overall survival. So the study proposed 2 arms until progression on more than 700 patients. And interestingly, the median age was 73 years. So really an elderly patient population. And in terms of PFS, you see the outstanding PFS with DRD in this paper updated a few weeks ago. The median PFS is not reached, and the 60-month PFS with DRD is above 50%. So that's what we were using, well, that were the results of stem cell transplantation something like 10 years ago. So for a very elderly patient population, to my opinion, the PFS data are outstanding, taking into consideration that the control arm, Lendex, is also a very good one, with a median PFS of 34 months. And that's quite close of the VRD study from the SWOG 77 results, in fact. And when looking at overall survival, very good results as well, and the median OS will be something like 10 years potentially when looking at this overall survival data at the bottom of the slide with hazard ratio of 0.68. So I think that DRD is, to my opinion, the best regimen that can be proposed to elderly patients. And when looking at frailty subgroup analysis of MAIA, that's not yet published, will be published soon, to my opinion, you see that there is also a clinical benefit of DRD regardless of the frailty status. But for frail patients, the outcome was not strictly identical in the daratumumab arm, and as well, the treatment discontinuation rate was higher in frail patients, and the death rate is also higher in frail patients. What about toxicity into MAIA? We have a higher rate of neutropenia in the DARA arm, translating as well into a higher rate of grade 3 or 4 pneumonia as compared with Lendex alone, I would say as expected. But we have to keep in mind that these combinations are very, very expensive when using upfront a CD38 antibody. And we also looked at these 2 papers, one looking at the cost effectiveness of analysis of VMP plus daratumumab, and also the cost effectiveness of frontline DRD into MAIA. And the conclusion of this paper from the GCO is really highlighting that currently the combination of DARA with Lendex may not be cost effective under current pricing, and that's a big issue in many, many countries for drug access and drug reimbursement. And I thank you for your attention, but now let's go back to our case, in fact. So 70-year-old female, ISS 3, symptomatic multiple myeloma. What are you proposing, in fact, in terms of treatment? Please vote. So some changes, in fact, DRD, we are moving from 47% to 60%. So that's, well, I would say quite logical, but interesting now, Brian, to discuss about these results.
Thank you, Philippe. Well, as you noticed, I did vote for DRD in an elderly patient. I'm impressed with the data. It's unfortunate about the cost, but there's no question that the PFS and now the overall survival data are impressive. But let's turn to our panel, Vincent and Tom, for example, who were focused on a Velcade regimen. Vincent, do you want to comment on the pros and cons of VRD versus DRD, for example?
Sure. Thanks, Brian. So we are talking about the non-transplant population where we are.
This is the non-transplant, yes.
Correct. Where we have a choice between using VRD or DARA-RD. I think the
Yes.
key is to remember that when we say VRD, we are talking about 6 months of VRD, and then it's only LEN. So in terms of convenience, toxicity, and what the patients have to endure, the cost, that's 6 months of triplet and a monotherapy after that. And you can get 4 years PFS with that, Dr. Dury's trial. With DARA-RD, the results that you see are the results of giving the triplet for 5-6 years. And that's, you have to take that with what's the extra cost, what's the toxicity, what does daratumumab do to antibodies and COVID response, and all those factors. And it's not that straightforward. You cannot compare 2 phase 3 trials done in 2 different decades and say like, oh, DRD is better. So when I look at it in my algorithm, I say either one is okay, recognizing that there are pros and cons that you have to go through with each patient and decide. Cost is not trivial. Cost of daratumumab, even in a country like India, which has a ton of generics of lenalidomide, $150 for lenalidomide in India, $15,000 for lenalidomide in the US. But DARA is about the same cost. So 1% of Indians can afford DARA, but 99.9% can afford VRD. So you have to take everything into consideration when we make these calls, and I don't want to make just overt declarations that one is the standard of care. I feel either one is okay, and I don't think you're going to run into a huge survival difference if you gave VRD first and then DARA, or DARA-RD first and then V.
Right. Okay. We don't have a lot of time, and so maybe Tom, maybe you could comment on the question of the triplet versus the quadruplet in the transplant population. Do you want to tackle that?
Sure. I do think that the exciting results from DARA VRD, which we're going to hear update, today at this ASH, is really where we're all going. I think everybody believes that quadruplet will be frontline therapy for multiple myeloma. The reason I didn't select it is because I can't essentially do it just yet in California because it's not approved by insurers, and it is expensive, like Vincent was just saying. But I think a quadruplet therapy followed by a transplant, followed by a consolidation, and then maintenance is where we're headed in that direction. So I do think a quadruplet's going to win over a triplet. And there's quite a few phase 3 trials now in transplant eligible and in transplant ineligible, comparing CD38 antibody plus RVD versus RVD. And I will say there's going to be first data from the German myeloma group. Dr. Goldschmidt's going to present data using isatuximab RVD versus RVD after induction therapy, showing a much higher MRD negativity rate in the quadruplet versus the triplet. And maybe that phase 3 will be the first one that'll enable us to use CD38s as frontline therapy. So yes, I think it's only natural for us to believe that quadruplet is where we're going.
A follow-on question. There are a number of questions about the duration of therapy. Do you want to just comment on that? If you follow on in terms of the duration of therapy and what the maintenance should look like.
Well, I have quite a few patients actually that we treated on the Griffin study, and I thought the Griffin study was quite easy to administer to patients. They got 2 years of daratumumab with lenalidomide as maintenance, and then after that it was kind of dealer's choice. And so I've kept people on lenalidomide as maintenance. So they get 2 years of dara-rev or lenalidomide, and then my patients are on len maintenance, and they're doing extremely well. So that's what I would propose would be the current standard.
Hey, Jesus, yes.
Yeah, I have a question for Philippe. KRD, the data that you have shown, very extremely attractive, the Forte data, but we have the comparison between VRD versus KRD with no difference, although high-risk patients were excluded. Therefore, how do you conciliate the discrepant results?
Oh, that's a difficult question, Jesus, but the patient population was not identical. You know, in the study comparing VRD versus KRD in the US, patients were not supposed to receive stem cell transplantation, with many patients that were elderly patients. And that may explain why we have these identical results when comparing VRD and KRD. We don't have any head-to-head comparison of VRD versus KRD yet in transplant eligible patients with the same number of cycles from 4 to 6 prior to stem cell transplantation. So, and you know that in Europe, we are not mentioning KRD as an option prior to stem cell transplantation because this combination is not approved. So that's why I mentioned the EHA and ESMO guidelines showing that we can use either VRD or VTD DARA yet, and a second option, VCD or VTD.
Okay. All right. Well, we're running a little short on time, but great presentations, Philippe, and very strong data. Really, we're very fortunate. Thank you.
Brian, can I make one comment?
So I'd like us to move on now to our next segment, which is with Vincent Rajkumar, who has got his mask off and I think is ready. So Vincent is going to look at the tailoring of management for patients with myeloma in first relapse. So Vincent, welcome. You're going to go to the podium. This is yes.
Yes.
We are sitting in our chairs here, but you get to go to the podium.
Yes. Actually, welcome. It's really great finally after like 2 years to meet in person. This is the first time I'm doing a trip in the US to go to a meeting. I feel very safe, very privileged that all of us are able to connect again and try to stay safe throughout the meeting. The talk I'm going to give right now is how to manage patients in first relapse. Here are my disclosures. And we'll start with a case, a very simple situation that we encounter. 52-year-old patient presents with relapse myeloma, presents with right leg pain. We have a lytic lesion in the femur. PET scan shows increased FTG uptake in the lesion as well as enhancing lesions in the lumbar spine, both humeri and multiple ribs. He was diagnosed in the past with standard risk myeloma 4 years ago, underwent 4 cycles of VRD followed by transplant, achieved a CR, and has been on len maintenance, 10 milligrams. So symptomatic relapse with actual bony lesions while the patient is on lenalidomide. The current labs show hemoglobin of 11.5, calcium 10.5, creatinine 1.1, M-spike 1.5. Kappa free light chain is 110 milligrams per liter, lambda 10, serum free light chain ratio of 11, bone marrow plasma cells 40%, and deletion 17p present on fish. Okay, clear-cut relapse on len maintenance. What would be your preferred first relapse regimen? Belantamab, carfilzomib len-dex, a CD38 monoclonal antibody len-dex, a CD38 monoclonal antibody with carfilzomib dex, and CD38 monoclonal antibodies either dara or isatuximab. Selinexor bortezomib dex, referral for CAR T therapy or uncertain. Please vote. Okay, so 66% pick a CD38 monoclonal antibody, carfilzomib and dex, and the others are very little. Let's go with what the panel preferred, and that's pretty much everyone said the same thing. So you're all in good company. We are all in good company too. And referral for CAR T therapy with Dr. Tom Martin, and we'll ask him for his rationale. First relapse for CAR T. So this is my simple acronym for selection of a regimen, not just for first relapse, but any relapse. Relapse myeloma therapy selection is actually a little bit more complicated than newly diagnosed because it really depends on when is the relapse occurring, how long after the patient was initially diagnosed. A relapse within a year is different than a relapse that occurs 4 years later, like in this patient. How did the patient respond to the previous therapy? If somebody took VRD, had 4 years of PFS without any maintenance, and now they're relapsing, is very different from somebody relapsing after failing the first-line therapy. How aggressive is the relapse? Is it only paraprotein, or like in this patient with lytic bone lesions? And what is the performance status of the patient? What kind of treatments can they tolerate? So that's TRAP. I keep this in mind when deciding what regimen to pick. Now, there have been multiple randomized trials done in the 1 to 3 relapse, primarily first relapse setting, trying to identify regimens that are effective. There are 6 of them that I've listed here that came out around 2015, 2016. They all looked at either Len-Dex or bortezomib-dex as a doublet and compared it to a triplet with daratumumab, elotuzumab, carfilzomib, and I think I have there panabinostat, and ixazomib, and each one of them found that the triplet was better than the doublet. But unfortunately, there are 2 problems with these trials. One is that these trials did not look at a population that is lenalidomide refractory, patients who have failing on lenalidomide. So they don't apply to our patient today who is relapsing while on len maintenance. Second problem is that all of these are doublet versus triplet. There are no trials comparing a triplet versus a triplet for me to decide, should I use dara-len-dex? Should I do dara-bortezomib-dex? Should I do KRD? They haven't been compared head to head. So it's really, we are stuck with having to decide without randomized controlled data. I have marked here in the blue font highlighted, the DARA studies seem to show the best hazard ratios with a 60 to 70% reduction in the risk of progression compared to the other regimens which are more in the 30-35% range. Thankfully, since these trials came out in 2015-2016, in the last 5 years, we've had many other studies which have included patients who are previously exposed to lenalidomide and now they are relapsing. And I will highlight about 5 of them. Daratumumab carfilzomib-dex versus carfilzomib-dex. And here, of course, we have no IMiD, and so we can look at how they did. And you can see here Dara carfilzomib-dex doing quite a bit better than the doublet of carfilzomib-dex. The same thing has been looked at with isatuximab, which is similar to Dara in that it's another CD38 monoclonal antibody. Same thing, isatuximab carfilzomib-dex versus carfilzomib-dex. Again, the triplet here looks superior. You can keep the IMiD but change it from lenalidomide to pomalidomide, and again randomized trials have been done. There are POM-dex versus POM-dex. You can see the triplet again showing better PFS, significantly better, and same thing with isatuximab, and you can see that whether you use Dara or isatuximab, the outcome is similar, that you improve outcome compared to the doublet. Besides these 4 trials, there's one other trial I want to highlight, that's the Optimism trial, which used pomalidomide plus bortezomib versus a bortezomib backbone, and again showing benefit over the doublet. What is important about these 5 trials is that these 5 are regimens that you can use in patients who are IMiD refractory, who are lenalidomide specifically refractory. And so my algorithm for first relapse is really looking at whether somebody is refractory to lenalidomide or not. If the patient's not refractory to lenalidomide, that means the relapse is occurring while they are not taking any maintenance, or maybe they're on 5 milligrams of lenalidomide or even 5 milligrams every other day, very low dose. then you can certainly go with daratumumab lendex because the patient's not yet refractory to len, and dara lendex in the first relapse based on the Pollux trial gives you extraordinarily good outcomes in both PFS and overall survival. Of course, there are alternatives. You could use KRD, IRD, or ERD, but dara-RD gave you the best hazard ratio in that table that I showed you. But like in this patient who's relapsing while on lenalidomide with symptomatic disease, lytic lesions, and serious problems, patient's refractory to len, and I have put 4 regimens on the left-hand side, dara-KD or ISA-KD, dara-PD or ISA-PD, because really there's no good data to tell me which of those 4 regimens is better. And I don't think you'll be wrong if you chose any of the 4, depending on your circumstance for where you have drug availability, approval, and so on. I will comment that particularly in the United States, if you compare daratumumab sub-Q and isatuximab, for certain patients, particularly those who weigh 60 kilograms to 65 kilograms or less, isatuximab could be half as expensive as daratumumab. So please take cost into consideration, because I've been an advocate that if you have 2 or 3 monoclonal antibodies, it will spur competition, and that competition will reduce prices. But that will happen only if we are willing to use the cheaper drug. If we are stuck on what we always use, then that won't happen. Companies will reduce cost depending on whether practice is looking at cost as a factor. So I've put all 4 look good, and you could pick any of them. But what happens if a patient is also refractory to daratumumab? We just heard studies where patients are getting daratumumab lendex as their frontline regimen. So when they relapse, they'll be refractory not only to lenalidomide, but also to daratumumab. And in that situation, carfilzomib-based regimens are my go-to. You could use carfilzomib Pomdex if the patient is lenalidomide refractory, or you could use carfilzomib lendex if the patient is still len sensitive. And I have given some alternatives also for you in this slide. I leave you with this. I don't think you make a mistake picking any of these great regimens. If you choose one and the patient relapses, you go to the next. I don't think you change the outcome if you chose dara-KD first and then went to some other KPD or something else later. I think as long as you give the patient all available regimens in a logical fashion to make sure that you've used all the drug classes, you will get similar outcomes. But the principles are important. The principle is try and use a triplet. We have like literally 11 randomized trials showing a triplet gives far better PFS and in most cases better overall survival. At least 2 new drugs. If you're changing the regimen, change to a regimen. Dex is same, so you change the other 2 drugs so that you give the patient the best option of responding. Don't forget transplant. There are still in the US half the patients not getting transplant in the newly diagnosed setting. Many of them have stem cells collected. Transplant is a wonderful regimen, and it can give you a prolonged PFS, particularly for patients who have not had it. Or even if somebody has had it and they had a very good outcome and they have stem cells collected, or you can collect, they can get a second transplant at the time of first relapse. So don't forget transplant, and then always consider clinical trials, because that's how we have made all of these advances. So let's go back to our case. We already started at 65% for dara-KD, so I don't know how much we're going to improve. Same patient, relapsing while on len maintenance. What would you choose? Please vote.
Okay, well.
We've overwhelmingly changed the thing. Thank you very much. Appreciate it.
All right. So thank you, Vincent. There's applause when you give a talk in the room. No applause for us when we're virtual. So there's a simple question, Vincent. If a patient relapses on LEN maintenance, is that patient considered resistant or refractory?
You know, I have changed my mind on this over the last few years. Initially, I thought when somebody is relapsing on LEN maintenance that you could continue the LEN and add DARA. But in practice, as I've done that, I have not found great results, and particularly symptomatic relapse. So if they're on 10 milligrams or 15 milligrams of LEN, I consider that refractory. There are some patients who, for whatever reason, they're on 5 milligrams of LEN or 5 milligrams every other day, or 2 weeks on, 2 weeks off. Those patients may or may not be LEN refractory, but oftentimes there is a reason why they're on 5 milligrams. They're not able to tolerate even 10. So it's not really practical to put them back on 25 milligrams of lenalidomide. So since we have pomalidomide and we have other good regimens, I would consider 10 milligrams, somebody progressing on maintenance LEN as LEN refractory for practical purposes.
Thank
Brian?
you. Yes, Vincent.
I have a question
yes.
for Vincent.
Yes.
In the last algorithm, you have shown that the CD38 plus KD as equivalent as the CD38 plus PD in the LEN refractory setting. But my personal feeling is that the trials indicate that probably the combination of CD38 with carfilzomib will be better in the LEN refractory patients. Can you comment on this?
No, you're right, and I did that only to be fair in the sense that they haven't been compared head to head. We actually proposed a trial for the NCI steering committee, believe it or not, DARA KD versus DARA PD, for which there is zero data and no advice on whether we should change the class of the drug. Unfortunately, the people who reviewed it felt like it was not novel or interesting. So I don't know the answer, but I tend to agree with you, and that's why I didn't want to confuse the audience. I didn't give that option in the multiple choice. I think I would personally favor DARA KD as well. I just put the 4 options there for being fair.
But Vincent and Jesus, you are totally right. I think that when we are looking at Icaria and Apollo, the studies looking at Pomdex, isatuximab, and Pomdex Daratumumab, they were proposed for Icaria in patients with 2 or more prior lines of treatment. And Apollo, 90% of the patients were also at the time of the second relapse, as opposed to Bcma and Candor with KD Dara or KD isatuximab. The patient population is not identical, and many patients were enrolled at the time of the first relapse. So that's difficult to compare PFS, very good PFS with KD Dara or KD isatuximab versus PD Dara or PD isatuximab with shorter PFS, since the patient population were more advanced in the trials looking at Pomdex as a backbone.
There's a question which has come in, which is, what do we think about the treatment for biochemical relapse versus clinical relapse? There are actually data from the Mayo Clinic presented at ASH this year, I noticed. Vincent, do you want to comment on that?
So, you know, in the past when we have looked at, I'm not sure which abstract at Mayo that you're referring to. We had like 80, so I'm blanking.
I know, it was Angela Dispenseri, I think, looked at that.
Okay.
Yeah.
But what we have found, and I think many of you have been on review committees for relapse myeloma trials, for independent review committees. My impression is that when patients relapse biochemically, within a month or 2, they will have some clinical feature, and that's why we are a little bit more anxious about treating them. There are some patients who are biochemically relapsing very slowly that you could probably just control with just modifying the dose. For example, you're on DARA RD, and once they go into DARA once a month, the M spike slowly starts drifting up. And I've just gone back to more frequent DARA and controlled it rather than change the whole thing. But other than that,
Right.
Most of the time you're just better off changing the regimen.
Right.
I don't know, Tom, or anyone else wants to comment.
No, I think that's fine. Actually, I think that we're tight on our schedule here, so I think we do need to move on. There are a number of questions, some more complicated, that would take some time. So perhaps, thank you so much, Vincent. Let's move on to the next topic, which is actually myself talking about triple class refractory myeloma, excluding BCMA targeted therapies. So I'm glad to have this opportunity to present. I'm actually presenting because Shaji was not available to us this year, and so normally Shaji Kumar would actually have been presenting on this particular topic. And so we selected a case here, triple class refractory, a 67-year-old woman who started out with standard risk IgG kappa myeloma, with some trisomies, deletion 13, but no bad risk cytogenetics. First therapy, Revlimid and Dex, with a good PFS. At relapse, treated for a second line with Velcade Cytoxan Dex, and at that point was refractory to both IMiDs and proteasome inhibitors. As a third line, Dara was introduced, Dara Pomdex. A response was again achieved, but ended up being refractory to anti-CD38. And then as a fourth line, received carfilzomib and Dex. And so the main thing to be said about this particular patient is that she progressed and was really not in good condition, with a low white count, anemic, and some low platelets. And unfortunately, this is a situation that many of us are seeing more and more, patients with refractory disease, perhaps not in the best of shape and maybe not eligible to get into many trials, which has become quite an issue for us. So if we look at what actually can we do for this kind of patient in current clinical practice, what would be your selection? Selinexor combination, cyclophosphamide combination, BD-PACE, venetoclax, refer to a center for a BCMA therapy, hospice, or uncertain. Okay, so I think pretty clear that access to a BCMA-directed therapy would be preferred. And as you'll see in my upcoming presentation, this is very reasonable. Okay, so let's go ahead. I think, what did our experts say? Myself and Tom, we said a cyclophosphamide-based regimen, but I think truthfully, that would be used maybe in an effort to have the patient qualify for a BCMA regimen. And the others would refer for a BCMA-directed therapy. So the approach to triple class refractory has really persisted as an unmet need in refractory myeloma. And if we look over on the left here, if we look at panobinostat, unfortunately, panobinostat was recently withdrawn. And so we have actually one less option available. And the other one, which had been on the slide, which is unfortunately no longer on the slide, is melflufen, which was also withdrawn. And so this has been a difficult area for new agents. We have venetoclax and selinexor, which I'll talk about in just a moment, and then we have the combinations of some traditional chemotherapy regimens. And obviously over on the right, you have all of the BCMA and other cellular therapies that will be discussed by Tom in just a moment. So obviously we are all pretty familiar with selinexor now, the XPO inhibitor, a unique mechanism of action. The STORM trial indicated the benefit of the selinexor plus Dex. However, I think we were all quite challenged by the side effects and toxicity profile, but clearly a level of activity and overall response rate 26.2%, even in very advanced disease patients like the patient that we have here today. Obviously, the selinexor was actually in parallel studied in a variety of combinations, looking for a good combination that would work well. Looking at Velcade, carfilzomib, pomalidomide, and then daratumumab. Perhaps just draw attention to the Velcade, which was the basis for the Boston trial, which I'll show in just a moment, and the carfilzomib with actually impressively good results as a combination versus the other regimens. So that carfilzomib selinexor does have some deeper and higher levels of response. The Boston regimen we're familiar with, selinexor Dex versus selinexor bortezomib Dex. The once a week regimen and the combination with the bortezomib, as Sagar Lonial always says, it's as if the bortezomib worked as an elixir for selinexor toxicities, and that the toxicities were definitely less in the 3-drug combination. And the Boston trial results show the response rate and the improved PFS with the 3-drug combination. I think that the challenge with selinexor is the toxicity for sure, and this just illustrates the lesser toxicity with the weekly versus the twice-weekly dosing. And so for those considering to use the selinexor, certainly the once a week is something which is quite important. Venetoclax, we've been disappointed with venetoclax because it has such promise in translocation 1114, both as monotherapy and with Dex, and as I'll show you in a moment, with combinations. With daratumumab, we do have data indicating some good combination results with daratumumab, venetoclax Dex, especially in the 1114 population. The Bellini trial was a cautionary tale, as it says on this slide here, and unfortunately, these data will be updated at this meeting actually, with the cautionary tale being that if you look on the left, you do see the PFS benefit for the venetoclax combination. However, this did not translate into overall survival benefit. And so this was really something that came strongly to the attention of the FDA, and really, I think for the first time recently, had them start to look more closely at PFS and overall survival in these kind of trials. And this is actually what led to the withdrawal of melflufen, as a matter of fact. Next slide. So we can see here, if you look exclusively at the 1114, there continues to be tremendous promise for venetoclax in the L1114 population, but as we'll hear here at ASH, we will have the follow up on the overall survival, which in the total population continues to show the same trend as we've seen in the past. And so in this patient population right now, it really is tricky based on the commercially available drugs and in considering possibility of eligibility for a trial, both of which are not great for this type of patient. A selinexor-based regimen, absolutely a triplet using a once-a-week dosage. If the patient happens to be 11-14 positive, a triplet could be promising. Unfortunately, melflufen is not available, and some data will be presented at ASH so that you can see the details of that. But if the patient is eligible for a trial, maybe consider that. More to come on the BCMA agents. So there are treatment options available for this type of heavily pretreated patient. Available label options are not large at this point. I think that this is a huge opportunity to look at the various BCMA therapies as well as the new targeted therapies, which we're going to be talking about in just a moment. So let's go back to the case. I think you probably remember it, a lady who worked through the various regimens, ultimately becoming refractory to IMiDs, proteasome inhibitor, CD38, and then also carfilzomib, and looking to try to have some efforts at disease control. Options, if you could vote again, please. Yes, very much the same. But there was some slight increase in the option to consider selinexor in a combination, which I think is definitely reasonable. Okay, so thank you for that. I don't know if any of our panelists would like to comment about the difficulty right now in handling such patients with commercially available options. Tom, I don't know if what's your perspective on this?
Yeah, thanks, Brian. So, in this case, this person had rapidly progressive relapse disease, and those patients are very tough to treat. And honestly, it's not universally available, any BCMA therapy at the current time. It's actually difficult to get patients on BCMA targeted therapies. And so you have to actually, in my mind, take this person to therapy right away. Selinexor and Dex, or PI plus selinexor and Dex, are a great option. But also in somebody that has low counts, you potentially can do cyclophosphamide-based induction therapy. And like what Dr. Rajkumar said a few minutes ago, if you get this person in response, this person is 67, didn't have a transplant, you might consolidate them actually with an autologous transplant and be able to get some significant progression-free survival, and then get them onto a BCMA targeted therapy as their line after that.
Right.
And
but
to
very
echo,
difficult. Philippe, yes.
Yes, Brian, to echo Thomas' point, I think that's true that we are speaking about triple-class refractory or penta-refractory patients, and they are refractory to PI, IMiDs, and CD38 antibodies, but not all of them are refractory to alkylators. So we have to think again of using alkylators, and cyclophosphamide is definitely a good drug in this setting. And as mentioned by Tom and by Vincent, if we can use high-dose melphalan, that's definitely something that is feasible. And that's very, yeah.
I was thinking in the same line. If the patient has not received a transplant, the problem is that after 5 lines of therapy, it will be difficult to collect the stem cells. But since melflufen is not an option, I think we need to reconsider again melphalan. Melphalan is an active drug, more active than cyclophosphamide. The problem is cytopenias, but I would consider in many of these patients, if I have not other options, an alkylator, definitely.
Right, yes. Okay, well, thank you for that. I think we can move forward. I think that there is tremendous interest and excitement and tremendous potential, including for this patient that we were just talking about with the various immune therapy approaches. And so I'd like to move forward, if I can get the slides to move forward here.
But now Tom is going, at the end of his presentation, is going to get applauses.
Yes, that's right.
We have not got it.
He gets applauses, yes. So
we are jealous.
I'm not able to move your slides, Tom, here for some reason, but please welcome Dr. Tom Martin from UCSF, San Francisco, and who's going to talk about the evolving role of BCMA-targeted therapies. Welcome, Tom.
Thank you, Brian. And like Dr. Rajkumar said, thanks everyone for attending and being here. It's actually great to finally be back at a meeting, and hopefully it's a good and safe meeting for all of us. So I'm going to talk about BCMA-targeted therapies. We'll start off with a case. This is a 77-year-old male presented with standard risk IgG kappa myeloma. Beta-2 microglobulin was 3.2, and all other serum markers were relatively normal. Also is a hyperdiploid case, but had 1 Q gain. He's received 4 prior lines of therapy. And I do think in our charts now, we actually have to put in lines of therapy because insurers are looking at lines of therapy when we're looking down the road for BCMA-targeted therapies. So line 1 was RVD, followed by Rev maintenance. Line 2 is DaraPD. Line 3, carfilzomib dex. And then line 4, oral cyclophosphamide plus PD to try to recycle the pomalidomide. Now, he now presents with fatigue and low back pain, so 4 prior lines of therapy. The M protein is up at 2.5. Kappa light chain is about 150 milligrams per liter. He potentially has borderline hypercalcemia, and now you're considering therapy for this person. But options, again, for triple-class refractory myeloma are limited. So what would you do at this point in time for this patient? Number 1, recycle of agents, triple combinations. Number 2, a PI together with selinexor and dex. Number 3, belantamab. Number 4, a BCMA-targeted CAR T-cell. This is a 77-year-old, but age is not a factor with CAR T-cells. BCMA-targeted bispecific antibody on trial, a cyclophosphamide-based chemotherapy, or other novel clinical trial if available or uncertain. Go ahead and vote. Okay, so we have a lot of people being referred for a CAR T-cell therapy. I think that's a great answer. We'll talk more about that. And essentially, all the panelists also say, let's refer for a BCMA-targeted CAR T-cell therapeutic. And we'll, again, talk more about that as we go. Okay. So this is a strict question, and there's just one answer on this one. So what would your expectation for duration of response to salvage therapy be in triple-class refractory patients? So number 1 is belantamab mafodotin. The expected duration of response is less than 6 months. With selinexor or dex, the expected duration of response is greater than 6 months. With CAR T-cell therapy, ide-cel, the expected duration is 11 months. In cilta-cel, 22 months. In bispecifics, the expected duration is greater than 12 months, or the duration of response is not measurable with novel BCMA-targeted therapies, or number 6, uncertain. Go ahead and vote. Okay, so yeah, everybody, I think the majority of people hit it right. That the CAR T-cell, the expected duration with ide-cel is about 11 months, and the expected duration for cilta-cel is right around 12 months or 22 months. We'll talk more about that too. And then, what would your preference for sequential therapy using BCMA-targeted therapies be? Belantamab mafodotin first, then CAR T-cell targeting BCMA? Belantamab mafodotin first, then a bispecific antibody targeting BCMA? a CAR T-cell or bispecific antibody therapy first, then belantamab, or sequential immunotherapies that target different cell surface antigens like BCMA and then GPRC5D, or I would not give sequential BCMA targeted therapies regardless, or 6 uncertain. Go ahead and vote. All right, the majority of people would give a different cell surface targeted immunotherapeutic. And in fact, that's what most of the panelists also suggested. So let's talk more about some of the data that we have for some of these things. So I'm going to talk about BCMA targeted therapies. There we go. Can you advance? There we go. And so we have quite a few targeted therapeutics in multiple myeloma targeting BCMA. Not all that are approved right now, but let's talk about some of the data that got us to here today at ASH 2021. I'm going to talk about antibody drug conjugates, bispecific antibodies, and CAR T cells. And these we're going to talk about BCMA targeted. I will say that there are other targets that are under investigation that may actually be just as exciting, right? For GPRC5D, there's a number of abstracts at ASH, including a CAR T-cell therapeutic that we're going to see, and FCHR5. So these are really important therapeutics, also BCMA. Now in this slide, I show in the middle the approved BCMA therapeutics, belantamab, mafodotin, and ide-cel. And I will tell you, like I said before, there is not universal access to these drugs. Based on the toxicity for belantamab mafodotin, the requirement of a REMS program, and a good collaboration with ophthalmology, and with ide-cel, because right now there's limited manufacturing slots, and perhaps there's vector supply issues that limit our ability to use this CAR T-cell therapeutic. But on the right in green are a number of agents that are very exciting, a number that you're going to hear at ASH this year. And in fact, when we give this talk next year, we're hoping that many of these green will be orange. So I want to go back and just say, when we think about our currently available drugs, IMiDs, proteasome inhibitors, CD38 antibodies, our bar for getting them approved or to move them forward in development was an overall response rate, a single agent response rate in refractory disease between 20 and 30%. So in my mind, that was really a high bar. Now it seems like a really low bar, right? Belantamab is the only drug in phase 1 that had a response rate of 60%, but that was in mostly DARA naive patients. Now belantamab mafodotin is now approved for use in patients who have refractory and relapse disease after receiving 4 prior lines of therapy. It has multiple mechanisms of action, ADC or toxin-mediated cytotoxicity, ADCC, blocking ligand binding to BCMA in signaling, and also an immunogenic cell death. Now, it was approved based on the phase 2 DREAM study. I think everybody knows the design, but essentially in this randomized study, patients received either 2.5 or 3.4 milligrams per kilogram of belantamab every 3 weeks, IV, and the primary outcome was overall response rate. This was a heavily pretreated patient population. In fact, the median prior lines of therapy was 7. And if we look at what is the response rate now that they've had 7 prior lines, including being refractory daratumumab, the response rate goes from 60% as a single agent to 32%. But on the right, you see that there's actually a very impressive duration of response. The duration of response is 13 months. It's actually quite long. And for me, these data support the use of belantamab as a 5th-line therapy in patients who have triple-class refractory disease, especially if you don't have access to other BCMA-targeted therapies. Now, the problem, obviously, is ocular toxicity. We have 3/4 of the patients having keratopathy by a slit lamp exam. We have half of the patients having actual ocular symptoms. Mostly it's blurred vision and dry eyes. And we have 18% of patients that do have some visual change. Now that happens to be reversible. And I do think that the ocular toxicity is manageable. You just have to follow these patients closely. You have to use dose reductions, dose delays, and holding of the dose. you have to be on top of patients while they're receiving belantamab. So what's the future of ADCs? Well, with the belantamab, it's now being used in combinations with other agents and in earlier lines of therapy, with the hope that in combination with other agents, we can use lower doses of the drug and less frequent dosing of the drug to hopefully limit ocular toxicity. That is the key. And I do think that these drugs, especially belantamab, has a future in relapse and refractory disease. Okay, let's talk about bispecific T-cell engagers. Now, this is data from teclistamab. This was presented by Amrita Krishnan at ASCO in 2021. This was a phase 1 study that also had an expansion cohort. There was a 40-patient expansion cohort. And those patients treated at the recommended phase 2 dose of 1,500 micrograms per kilogram. There are 40 of them went on to receive this as a subcutaneous injection weekly. And here's the data. In terms of safety, CRS is seen about just over 57% of the time, but most of it is grade 1 and 2. Neurotoxicity, very low, 4.5%, but there was hematologic toxicity. It's mostly reversible. There was grade 3 or 4 neutropenia in about 40% of the patients. But look at the single agent response, 65% in the 40 patients that received the recommended phase 2 dose. And on the left, you see the swimmer lane plot showing that responses deepen over time and they appear durable. This is limited follow-up. I will tell you that Dr. Moreau will present the phase 2 data with 150 patients treated with this at the recommended phase 2 dose on Monday. And I suspect that it's going to be my favorite presentation and my favorite abstract at ASH this year. And this could lead eventually to accelerated approval of this therapeutic in the relapse refractory space. Now here's a summary of the biospecifics. I'll let you guys look at it, but this includes BCMA and CD3 targeted biospecifics in green, as well as other immunotargets in blue, and showing overall response rates at single agents now between 50 and 83%. Amazing overall response rates. And if we look in the red box, the CRS, that's the main toxicity. It actually is seen in about 40 to 70% of patients, but again, mostly grade 1 to 2. And it actually it is much more indolent than CRS when you give somebody a CAR T-cell therapy. This is very easily, in my mind, very manageable and very easy to control. And so in terms of bispecifics, I think these have a substantial future. I think everybody believes that. They will be used in all spaces in myeloma therapeutics, for frontline therapy, for high-risk smoldering myeloma, for consolidation, maintenance, early relapse, and in late relapse. And really what the race for all these agents that are in the race to win is to have outpatient dosing, low CRS, low neurotoxicity, and to be convenient dosing, hopefully sub-Q, and also infrequent. I think these drugs are going to allow Q8 weeks or potentially Q12 week dosing. And there's I show there what some of the updates at ASH are going to be. Well, what about CAR T-cell therapy? This is the KarMMa trial. As you know, this was published by Nikhil Munshi in New England Journal of Medicine, led to approval of ide-cel, overall response rate of 450 million cells of over 80%, with a PFS of 12 months. But if you look at the far right, the patients who achieved a CR, a stringent CR, had a longer PFS of over 20 months. And in fact, with CAR T-cell therapy, since it's one and done, you really have to achieve a CR, a stringent CR, to get that long duration of therapy. In addition, we looked and we see that T-cell expansion occurs rapidly, but over time, in the gray bar on the left, the T-cells are lost, and persistence is still problematic. In addition, responders had a high copy level of CAR T, so they had better expansion, and they also cleared soluble BCMA. On the right, if you did not clear soluble BCMA by 2 months, you see the gray line, relapse was imminent. Now here's the CARTITUDE-1 trial data. In the CARTITUDE, this is the highest response rate, overall response rate of 98%, median duration of response, again, of 22 months. And almost all the patients who were accessible for MRD were MRD negative. The 18-month PFS was 66%. This is going to be updated, the PFS at 24 months on Sunday. So stay tuned to the presentation on Sunday. In terms of CARs, The overall response rates, single agent, pretty amazing, right? 70 to 98%. There is more CRS, 70 to 90% CRS, mostly grade 1 or 2. There are some grade 3, and there's some neurotoxicity, about 20% to 30% neurotoxicity, mostly grade 1 and 2, but some grade 3s. Now, our envy of CAR T therapy in myeloma is shown on this slide. The upper bars are our colleagues with acute leukemia, looking that they have flattening of the curve. The bottom left is the KARMA PFS curve, the bottom right is CARTITUDE. We have to see what happens to CARTITUDE over time, but in fact, we need flattening of the curve, right? In the future of the BCMA CAR T cells, cure needs to be our goal, or they need a very long treatment-free interval. That really needs to be, in my mind, one and done. So our wish list for CARs is high. Faster manufacturing, better expansion, dual targeting CARs, etc. Now, we talked about some advantages and disadvantages over time, and I highlight these in the blue and the red boxes, and I'll let you guys look at it. So in the last minute, I'll just tell you what my sequence is, okay? So as of now, belantamab is actually the only easy and accessible BCMA-targeted therapy. It's easy for me because I have a collaboration with my ophthalmologist. It is off the shelf. If you can use it, it is a good drug. It's hard to wait for a CAR T-cell therapeutic or a biospecific trial slot on a patient that has active progressive disease. You got to treat these patients. Now, ide-cel is the only BCMA approved CAR, but we're hoping that in this first or second quarter of next year that cilta-cel will get approved, and hopefully we have better access to CARs. And my final is that biospecifics will eventually command really the largest fraction of the market. I think local docs will be able to give this, and all patients that come to the treatment center, like my center, an academic center, will have prior treatment of a BCMA-targeted therapy. Beyond 2022, we're going to have all these available. Again, for fit patients, I would do a BCMA CAR first. I don't think that cilta-cel is going to have a 98% response rate in patients who have been pre-treated with a BCMA-targeted therapy. It's going to be less than 98%, right? So I would do a CAR first if you can. In less fit patients, you choose a CAR, you choose an ADC or a biospecific, depends on what you can do and what you can give. And then if you have another agent down the road, you do another targeted therapy. Now, we are going to actually do a global immunotherapy database project through the IMF, where we're going to follow, we hope, thousands of patients over time to try to actually really find out which sequence of therapy was better. And with that, I'll conclude, and I thank you for your attention.
All right, thank you so much, Tom. Do you want to finish up with your case again and do the questions one more time?
Oh yes, absolutely. So let's get back to the case. Okay, so we have the 77-year-old standard risk myeloma, but at this point has been through 4 lines of therapy. And in the last line of oral cyclophosphamide and PD, he only achieves stable disease and progresses within 4 months. He presents symptomatic, so he's triple class refractory and needs therapy at the current time. So what are you going to choose now for this person's therapy? Go ahead and vote. All right, so we have a lot of BCMA targeted therapies. So we jumped up in belantamab, again, because we have access to belantamab. We jumped up with CAR T-cell therapy because there is no age limit for CAR Ts, and it is the most active therapy with deep and durable remissions.
Yeah.
Very good.
So very good to see that feedback. Okay, well, Tom, I have to say, a very, very comprehensive review of very exciting cellular, bispecific, monoclonal antibody therapies, BCMA targeted, and then the newer non-BCMA. So really a tour de force in summarizing all the information, I have to say. So we're grateful for that. Questions or comments from the panel? Jesus, yes.
Tom, I have a patient that is 58-year-old, and I have the chance for this patient to offer VRD in a clinical trial, VRD or KRD, whatever it is, induction, followed by the CAR-T, or to go into the conventional approach. What do you recommend to this?
Yeah, Jesus, thank
The
you.
experimental versus the
Yeah,
conventional.
thank you so much for that question. And I think many people know that I've already bet my whole wine cellar that we are going to do VRD followed by a CAR T cell, and we are not going to be doing VRD in an autologous transplant 5 years from now. We are going to completely switch to CAR T cell therapy in my mind. I do think that the responses are deeper, they're more durable, and I think it's much less toxic than autologous stem cell transplant. And that's my opinion.
Yeah.
Okay.
Very, very good. So Philippe, maybe you can comment on this. What about teclistamab in that setting? How do you see the role of the bispecific versus the CAR T? Do you agree with Tom? We'll be looking at CAR T first, or what do you think?
No, I think that Tom really did a good job in showing all the data available, and I agree with him. In fact, CAR-T, that's one shot, and we have quite a long treatment-free interval in patients that are very advanced. So I would favor CAR-T therapy first, and then subsequently a bispecific antibody with a different target if possible. I agree with this proposal. But Jesus highlighted a very important point. Do we think that bispecific antibodies or CAR T cell therapy will replace autologous stem cell transplantation in the future? And you know that we need to demonstrate, of course, this efficacy and these combinations. But in Europe, we are going to start a study looking at VRD Daratumumab, and in MRD negative patient, we are going to propose bispecific antibodies for these good risk patients. And then the next step will be potentially a randomized study comparing VRD Dara stem cell transplantation versus VRD Dara bispecific antibody, or VRD Dara followed by a CAR T cell therapy. But this is the way probably where we are going to go in the near future.
Yes, and bispecifics are obviously a lot easier to manage in this kind of a randomized trial setting. So, Jesus, what do you think?
Can you repeat just to be sure? Because I'm not sure that I got a question. Brian?
Do you see CAR T replacing autologous stem cell transplant, basically?
Okay, because I was not sure if it was replacing or following.
Okay, all right.
This was my doubt, according to the design that Philippe has been mentioning. I think in a patient like the one that I propose, I will collect stem cells, but I will go for a CAR T upfront.
Okay.
But I will keep the stem cells for a backup. And the reason for this is because I agree totally with Tom that CAR T induces much deeper responses and is associated with should be associated with longer PFS, particularly in the setting of a healthy T cells that we are going to use for these patients. But I will keep the stem cells for eventual relapse to use.
All right. Okay, well, to leave time, we'll have some time at the end for some across the board questions, but I'd like to move now, Tom, to the final segment number 7, which is a popular segment. Is one where Vincent summarizes with Philippe the different algorithms. And so can we move to that, please? And I believe, Vincent, you will be starting.
Yes. So we've done this for the last several years now, where we summarize this whole meeting in terms of how we would approach a patient with myeloma. And I usually start off by saying I would rather nobody follow these algorithms, but you put patients on clinical trials. We have trials for smoldering, newly diagnosed, relapse, first relapse, 10th relapse, everything. So try and as much as possible put patients on trials. But this is how I would approach a patient. Given everything we know, given the imperfect evidence that exists, we have to make some decisions. So starting with smoldering myeloma, potential newly diagnosed patient with myeloma or smoldering, clearly everybody agrees that if someone has myeloma defining events, we would treat as multiple myeloma. But if patients don't have myeloma defining events, but they have, say, more than 10% plasma cells, and you're calling them smoldering, then you really need to split them into those who are high risk and those who are intermediate or low risk. The high risk is defined as a time to progression of median of 2 years. And that's about 1/3 of all smoldering patients. 2/3 of patients with smoldering myeloma are intermediate or low risk. The intermediate or low risk patients, clearly observation is sufficient. For the high-risk smoldering myeloma patients, based on the 2018 Mayo criteria or the IMWG criteria, really we have data now will have a 90% reduction in risk of end organ damage, either lytic lesions, renal failure, and so on, with early therapy with len or lendex for 2 years.
There we go.
And then clinical trials, if they are available, would be the alternative. The next slide is for newly diagnosed myeloma patients. We just heard a lot of presentations from Dr. Moreau. For non-transplant candidates, there are 2 good options. One is VRD followed by len maintenance, and the other is daratumumab lendex. And as I discussed earlier, they're both reasonably good, and you could consider either of them depending on the circumstance. For patients who are transplant candidates, we've also heard that quadruplets are coming in, particularly DARA-based quadruplet, DARA-VTD or DARA-VRD. We have data from Cassiopeia that DARA-VTD is highly effective from phase 3 Griffin and with DARA-VRD. Either one is reasonable. I personally prefer VRD for standard risk and the quadruplet for high risk until I see phase 3 data, but I wouldn't quarrel with my colleagues who are already willing to move on to DARA-based quadruplet. We are doing a randomized controlled trial in the US called the Equate Trial, which is asking the question whether everyone needs a quadruplet. And basically in that trial, the hypothesis is that if somebody is MRD negative with a triplet, they don't gain from the 4th drug, so we can minimize cost and toxicity. After you've given the induction for transplant candidates, the real process that most of us endorse is autologous transplant followed by maintenance, and the maintenance is len alone for standard risk and len plus bortezomib for high risk. The gray area is the IFM trial after 8 years of follow-up shows exactly the same overall survival, 60%, with either early transplant or delayed transplant. And so if the patient is really interested in a delayed transplant and your facilities allow that, then you can store stem cells, give 4 more cycles of VRD, but remember to do the transplant at first relapse. And here's where I will invite Dr. Moreau to give his comments on how a European perspective would differ from what I just presented. Philippe?
Thank you, Vincent. And in fact, very few differences when you are looking at the algorithm in Europe. When patients are not transplant candidate, I'm exactly on the same page, with DRD as first option and VRD followed by len, based on the SWOG study. That is also a very effective combination. And we mentioned as a second option, VMP DARA or lendex. So very similar choices, in fact. And for transplant candidate, we are proposing either VRD or a DARA-based quadruplet induction. VRD DARA is not yet approved, but to be honest, in some centers, we are anticipating a future approval of VRD DARA. So some of us are already using VRD DARA, and that's very similar to the US. And we put second choices that are VCD or VTD when VRD is not available or a quadruplet not available. But to be honest with you, VRD is not officially approved by EMA prior to stem cell transplantation, but that's a very, very popular regimen. And then after induction, stem cell transplantation and LEN for standard risk, LEN plus a PI for high risk. This is also something that we are doing in routine. Fully agree with you, Vince. And I did add Tandem for high risk disease that is recommended into the guidelines as well. Maybe in the future, we are going to do less and less Tandem because we don't have data with quadruplet induction followed by tandem stem cell transplantation. Maybe with a quadruplet induction, the results will be good with a single, and we will not need tandem for high-risk disease. And we are not proposing in the majority of the countries a delayed stem cell transplantation in front outside clinical trials. We are still strongly supporting the frontline use of stem cell transplantation. So very, very similar, Vince, you see?
Excellent. Thanks, Philippe. I will just move on to first relapse. First relapse, as I showed you before, clearly if the patient is still sensitive to lenalidomide-based first relapse regimens, there are many of them. Dara-RD would be my go-to. If the patient's Dara refractory, then carfilzomib-based regimen, KRD. Patients refractory to lenalidomide, I said any of those 4 regimens, DKD, ISA-KD, DPD, or ISA-PD. You heard from the discussion the question of like, should we just change the drug class from an IMiD to proteasome inhibitor, and some of us favored Dara-KD or ISA-KD, but Dr. Moreau pointed out that it's hard to compare the phase 3 trials of an Dara-PI versus a Dara-pomalidomide because the populations are different. If the patient's Dara refractory, then again a carfilzomib-based regimen would be reasonable. I'll ask Philippe to comment on his any changes to this from a European perspective.
Thank you, Vincent. And well, I put the same, almost the same algorithm. When patients are not refractory to lenalidomide, either len sensitive or len naive, DRD probably is the first choice based on the Pollux study that was updated, in fact, by Nizar Balis, showing an outstanding progression-free survival at the time of the first relapse. That's also true for len-exposed patients, len-sensitive. And we are also proposing alternatives, including Lendex plus Carfil, Lendex XA, Lendex ELO. Some of them are associated with an overall survival benefit. We mentioned KD, Dara, KD Isatuximab, based on Bcma and Candor, since some patients were treated also at the time of the first relapse into these 2 trials. But definitely Pollux is the most popular combination. And when patients are refractory to lenalidomide, we put the same proposals based on the EHA and ESMO guidelines with KD Dara or KD Isatuximab as first choices. Pomdex Dara, Pomdex Isatuximab, they can be used at the time of the first relapse, but they are mostly approved for patients with 2 or more lines of treatment, not the first relapse, because the patient population, as we did indicate, are mostly more advanced with 2 prior lines of treatment. But in Europe, we are also using POMVD. That is a good choice based on the Optimism study published by Paul Richardson in the GCO, showing at the time of the first relapse, a median PFS of 18 months versus 9 with VD alone in this phase 3 study. So that's a randomized phase 3 study, and definitely a good combination in the countries where we don't have access to daratumumab at the time of the first relapse. And for Dara refractory patients, you did mention, Vincent, KPD, definitely a good choice, but POMVD can be also used in this setting, and Pomdex ELO can also be proposed. We have a phase 2 data phase 2 study showing that Pomdex can be of interest in the relapse setting. It was focusing on patients more advanced, 2 prior lines of treatment, but nevertheless, when patients are refractory to DARA, we can use elotuzumab as well, that is targeting SLAM F7 in combination with Pomdex. That's not available in all countries, but that's another potential choice. But very similar picture, Vincent. So we are all of us on the same page, today.
Correct. And actually, I have no disagreements with this slide. I just tried to force myself to pick one regimen. But again, I totally agree with Dr. Moreau. Any of these are reasonable options depending on what's available. When you come to second or higher relapse, the algorithms are really very hard to do because it really has many, many variables in terms of what the patients had and how they've responded to it. I think the principles are more important. Just make sure you do a triplet at least or a quadruplet, and then at least 2 new drugs that the patient is not refractory to. Additional options, and this comes into the penta-refractory patients that were discussed. I won't go through everyone, but just to point out, melphalan. I know Dr. Jesus San Miguel mentioned it, and I had written it down as well. I have used IV melphalan, and I'm sure my colleagues have too. You don't have to use IV melphalan just in the autologous stem cell transplant dose, where sometimes in the penta-refractory setting, it'll be very hard to collect stem cells if the patient's not already had the cells harvested. But you can certainly use it at a dose like 25 milligrams per meter squared, which is not myeloablative, and 25 to 40, but I've nowadays in practice settled to 25 milligrams per meter squared. IV, just 1 dose, and you can do 2 or 3 doses 6 weeks apart. Extremely effective, better than IV cyclophosphamide. So for a penta-refractory patient where BCMA targeted approaches are not really available, even though they are desirable, I would say do not forget IV melphalan. You can buy time with that. My problem with selinexor, bortezomib, dex, which was also one of the options discussed, was that was a study done in 1 to 3 prior therapies, not in penta-refractory. They did not take patients who were refractory to bortezomib. Our patients are usually refractory to bortezomib and carfilzomib. So you cannot just simply use selinexor, bortez, dex. So keep that in mind. Venetoclax is a great option, but primarily for 11-14. And then I have listed other regimens. Philippe?
Yes, thank you, Vincent. And as you see, we have exactly the same picture, first relapse options. That's exactly the same. And difficult choices according to drug availability, to drug reimbursement as well. In Europe, that's exactly the same. So we do have, for triple-class refractory patients, Bcma that is approved in Europe since August 2020. We are going to hear at ASH this year, in the next days, some dose adaptation of Bcma, because currently the dose of 2.5 every 3 weeks, many patients have to stop, to discontinue because of this ocular toxicity that was well discussed by Tom. And maybe we can use reduced dose of Bcma, or the time interval should be different as compared with the 3 weeks. But this drug is active for sure, and some patients are really benefiting from this agent. CAR T-cell therapy, you discussed about the issue of access to this immunotherapy, and definitely outstanding results with cilta-cel that will be updated during the meeting, and we are all of us expecting to have a larger access in the future. Selinexor dex, suboptimal to my opinion because of the toxicity of the short PFS of 2 months, and that's not widely used, I would say, in Europe. And I think that venetoclax, Brian nicely discussed the data on venetoclax, but for a patient with 11-14, I think that we should not forget this possibility. I think that during the course of the disease in a patient with 11-14, venetoclax should be systematically proposed at the time of the late progression. And cyclophosphamide dex, in fact, that's also very cheap, oral, quite manageable, I would say, and very few patients, in fact, are alkylator refractory when they are advanced in their disease as well. So this is something that I usually propose in my routine practice as well.
Okay, so thanks to you both. I think that's your last slide, I think, both, right?
Yes.
Yes. So very, very good all. So I think we just have a few moments here at the end to wrap up with any final comments. So
Brian,
yes,
I want to
Jesus.
make a comment. First
Yes.
of all, I think just to see the concordance between Philippe and Vincent is very good for the audience, because
Yes.
they demonstrate thinking in what is available in the different regions, that we can manage in a uniform way the myeloma patients and individualize. This is my first comment. And the second comment is regarding tandem transplant in high risk. For the audience, I would recommend, we use tandem transplant, but providing that the first transplant was efficient in the bulk of the disease. Because if the response with the first transplant is just to sustain the response, I will not go for a second one.
Okay, good thoughts. Fully agree. Yeah. So, any other final comments from anyone? Tom. Yeah, go ahead, Tom.
Yeah, I just want to echo something that Vincent said earlier about clinical trials and referring patients to clinical trials. These studies now that we're doing with bispecific T-cell engagers and CARs, these agents are so active. We have to test them in smoldering myeloma. We have to test them in newly diagnosed. We're going to have to do a lot of trials to actually get these approved in the earlier lines and show that these are actually better than we have now. So please, when you have a new patient, look close for a clinical trial. If you have an early relapse patient, look for a clinical trial, because these drugs are drugs that we're going to want to bring up, earlier in earlier lines of therapy as soon as possible.
Absolutely. Okay. Any final thoughts, Vincent? The algorithms, I think, were excellent as always.
No, overall, there is a lot of hope, and I think everybody is very optimistic. I mean, Tom's presentations where he showed all of the drugs we currently use had a single agent response rate of 30% or so, including bortezomib, lenalidomide, single agent, only 30%. The ones that are coming out now, all the bispecifics and the CAR-Ts are 60+% single agent response rate in a far more refractory population than we used to study bortezomib or lenalidomide. So the future is promising. At the same time, my worry is that there's a time lag between when these treatments become realistic for the majority of the world. And if you do DARA VRD for frontline and KPD for relapse, you've used up just about all of the active regimens, and you're suddenly, as in your presentation, Brian, you're suddenly down to selinexor and IV melphalan.
Exactly.
So
it makes it very difficult.
That gap between what's optimism for bispecifics and CAR-T and what's realistic in today or the next 2 or 3 years is going to be a tough thing. And again, referring to clinical trials, please keep calling and finding some bispecific or some other clinical trial, but it's easier said than done.
Absolutely. So I think we've reached the witching hour here. So a couple of comments in closing. First of all, to let all of our audience, virtual and in person, know that the slides that you have just seen will be available online very soon. So you will have access to those slides. But I'd like to just sincerely thank Philippe and Jesus for participating virtually, along with myself virtually in this kind of unique setup. It seems that it has gone fairly smoothly combining the virtual and the in-person, except that we didn't get any applause, of course, but thanks to Tom and Vincent, as always. I think that between everyone, this has been a very comprehensive update, and certainly we hope it has been useful to our audience. And we look forward to next year when we will have a packed room where we will all be able to see each other and interact in a more normal way. So thank you to everyone.
Thank you.
Thank you.
Thank you.